You want me to introduce?
Yeah, you introduce.
Okay. Do you want to lead off and just sort of?
Sure. Well, we will get started on time because there's going to be a lot of interesting topics to discuss. We want to leave some time for some discussion afterwards. So welcome to our career building in abdominal wall session. We're really excited for all of the presenters to come up today. And I'm sharing this with Dr. Nicole, who is at Oregon Health.
All right, up first is one of our favorites, Dr. Ivy Haskins, who co-directs the esophageal and GI motility program in Nebraska, and she is going to be talking about focused practice designation. Thank you.
All right. Well, thank you to AHS and the moderators for the invitation to present. So I'm going to be talking about practice focus designation, which is really the new hernia fellowship. I have no industry disclosures, although this is the product of Jake Greenberg, who's going to be talking later on in the session. So I hope I do it justice because there's a lot of good work that went into this. So brief outline, I'm just going to be talking about the evolution of current hernia surgery, why now in terms of developing this fellowship, and then what are the requirements for the hernia fellowship. So let's talk about the evolution of hernia surgery, and I've broken this down into a few different things. So this paper was recently published in Surgical Endoscopy. It reviewed the fellowship council case log numbers for the fellows, and you can see over this 12-year period that the number of hernia repairs being performed by fellows who are going into MIS surgery has almost doubled. And this is pretty consistent with the data that we're seeing from hernia surgeons as well. This is, does not show as many years, but the paper actually published on this, and it shows that our number of ventral hernia repairs that we're performing annually in the United States has almost doubled since 2006. So this is, our disease burden is increasing, and the number of hernia repairs that we're performing is also increasing. So along with that, our surgical approaches, the tools that we have in our armamentarium have increased a lot as well. And sometimes I feel like it's a little bit of alphabet soup because every day I'm hearing a new acronym to describe a different type of surgical technique. I'm trying to keep up with it. And I'm a hernia surgeon. A lot of my practice is hernia. So I can imagine as a trainee and a new surgeon coming out, keeping up with all of these new up and coming approaches is really, really challenging. And then dissemination of information, right? It's much easier to do now than it was probably a decade ago when we started looking at this. So many of us used to refer to textbooks, but we have, Vahag has a YouTube channel that details some of his tips and tricks in terms of overcoming some of these challenging complications. There's hernia-specific summits and meetings like the AHS meeting that we're at, surgical coaching, Facebook groups, all sorts of ways to get your information. And then unfortunately, it's just a hernia until it's not, right? So a lot of these patients start with small umbilical hernias, they get fixed, they have some sort of complication. You're seeing a patient back in clinic, it's their third, fourth, fifth time redo hernia, they now have loss of domain, maybe they have an open wound, a fistula. And so how do you start to manage these complex hernias, right? Because the game has changed at that point, which really segues into why now. So, to sit for your written exam for the American Board of Surgery, you need to do 85 total hernia cases. That includes both ventral and inguinal. And up until recently for the Fellowship Council, any of the MIS designated fellowships, you need 20 hernia cases to meet your criteria to get your certification. And so that really begs the question with all of this new technology, these cases, the complexity, is 105 hernia cases really adequate to be practice ready for all of the different types of hernia scenarios that you're going to encounter as a practicing surgeon? In addition to that, and this is like not an extensive list at all, but there's all sorts of drivers to improve the quality of care that we're delivering to our patients, right? So our national organization, Centers for Medicare and Medicaid, all sorts of governing bodies that are sort of looking at what we're doing, right? And so when you put this all together, you're seeing an increased volume of hernia patients. There's an increased number of surgical approaches, there's increased complexity, and you're having these drivers for quality improvement, which really, I think the simple answer is we need a hernia fellowship to really start teaching people how to be comfortable with all of these scenarios. And so what are the requirements of the hernia fellowship? So it's 100 total core procedures. So 30 are inguinal hernia repairs, 15 must be MIS, 10 must be recurrent. 30 ventral or incisional hernia repairs that are 3 to 10 centimeters in width or length. 15 must be MIS and extraperitoneal. 25 ventral or incisional hernia repairs greater than 10 centimeters in width or length. 15 atypical hernia cases, and those include your peristomals, infected mesh, subxiphoid, suprapubic flank, or fistula. 5 clinical evaluations for chronic pain after hernia repair. We're seeing a lot of chronic pain patients. Completion of the Fellowship Council curriculum, and then there's 8 EPAs specifically designated to hernia patients and hernia care, pre-op, intra-op, post-operative evaluation, and 5 of those 8 must be completed. And this fellowship is jointly sponsored by AHS and SAGES. So again, going back to that paper that I talked about before, they looked at the case logs from 2008 to 2019, and about 9% of programs and 9% of fellows would have achieved the minimum hernia fellowship case requirements. There was a pilot study involving 6 institutions last year, showed that this was feasible and could be attainable by some of our fellows and our fellowship programs. And so it's been fully implemented for this academic year. There's currently 2 programs that have a hernia fellowship designation. That's Cleveland Clinic and Penn State. And so in conclusion, ventral and inguinal hernia volume, complexity, and surgical approach options are increasing. The ultimate goal is continued delivery of quality care to our patients. Current resident and fellow hernia case volume requirements may not be adequate to achieve practice-ready training. And therefore, multi-society hernia fellowship requirements may address current gaps in hernia training. Thank you.
Thanks so much, Dr. Haskins. We'll have you, all of the speakers will come sit up for our discussion at the end. The next we have Dr. George from Columbia University, and he will be talking about hernia billing beyond the RVUs.
Good morning. Thank you for the introduction. My name is Philip George from Columbia University, and I'll be talking about hernia billing beyond the RVUs, although it's really just going to be about the RVUs, really. I have no disclosures, but this talk really only applies to the American healthcare system, which is broken in so many ways. But my mantra is, if you are doing the work, you are adding more risk. If you are adding more risk, you really should be getting paid for it. So again, not quite beyond RVUs, a little bit about terminology. CPT codes, these are numbers assigned to procedures. It's current procedural terminology, and each of those procedures is designated an RVU, or relative value unit, which is broken down into work RVUs. That's what we get paid. Practice expense, which goes into instruments and supplies, and professional liability, which goes towards malpractice. Yay. And how we decide the CPT code. So every 5 years, or when new codes come up, a group of folks with 21 people meet together. It's a combination of AMA and a CPT panel. There are people from medical societies, but it's also people from the insurance companies. There's a seat for the Blue Cross Blue Shield Association, the America's Health Insurance Plan, and so on and so forth. So there's a lot of people in that basket. But how we determine the actual values is when we determine those codes. The RUC, or the RVS Update Committee, determines the actual value for those codes. Again, they meet every 5 years or as codes change. Now we have those codes, we have the CPT codes. How do we get paid? So there's a conversion factor. So it's really based off the Medicare rate, which is the standard. In 2023, it was $33.89, went down 2% this year. And it's again going down another 3% next year, which is really what we're fighting for. Since about 2000, I think the reimbursements for Medicare has gone down to almost 20%. So we really have to sort of make that up if we want to have the same, quality of life and so on and so forth. The Medicaid reimbursements rates can really go anywhere from the lowest in Rhode Island, which is a 0.37 Medicare, and to Delaware is a 1.18. And commercial insurances are sort of a variable on these as well. So to really understand the codes, obviously experience is number one, but there are a lot of online resources. Findacode.com, AAPC, the forum associated with that, which is where billers can actually have discussions as well. CPT books is the book that I use from Optum, and of course, society bulletins can also help us as well. So along with the CPT codes, there's some CPT codes that actually need very specific ICD codes in order to get reimbursement. Some are extremely narrow, like for an injection code, you really need to have one set of ICD codes that gets reimbursed for that. But there's no change in reimbursement depending on the ICD code, unless you're in a fee-for-service model like joints. So hernia changes, I'm sure you guys are all familiar with this. I'm not really going to go into it because it's a very large topic. but you should all be very much aware of them. The new codes are 0-day codes, as in you can code for postoperative visits. You should be aware of the inpatient only codes, which are the larger hernia codes, where you have to explain to the insurance company if they go home that same day. And there are add-on codes which reimburse for practice expense only. My takeaways is overall there's a decrease for the more common cases for reimbursement. If there is any increase, it usually relies on postoperative billing for those 0-day codes. And I think it's really antithesis to the tenets of coding, right? If we want to get paid for these procedures, it should be all incorporated in that singular code, and we shouldn't have to make up for it afterwards. So the ACS has come up with a couple of bulletins. They really started in 2009 with the addition of the lap hernia codes. But at this point, they really do acknowledge billing for component separation. There's an update in 2017, which has more commentary on that. Most of it I somewhat disagree with, but billers and insurance companies really rely on this stuff. So this is extremely important to how we actually get reimbursed. So the most controversial code, the 15734 code, this is it. This is the description from the United States government on this code. It is a muscle, myocutaneous, or fasciocutaneous flap of the trunk. That's it. There's no other descripting factors on any government website anywhere or in their delivering of it. But, we use this a lot of the times for component separations. One of the most controversial ones is, should we be using this for Reeve Stopa? This is on that billing form, which quotes the ACS bulletin from 2017. Code 15734 may be reported only when musculofascial flaps are created by myofascial release. So it should be denied for everything else. But okay, then explain this. Okay, we have really good data showing that these retromuscular dissections can actually act as a myofascial flap, whether it's advancement, creation of the flap itself. A lot of groups are thinking outside the boxes. And from 2022, this is ACHQH, Ben Palouse, Mike Rosen and company, looking at different alternatives for coding for Reeve Stopa hernia repairs. They're looking at the adjacent tissue transfer codes. And the point of that is we're advancing the tissue to cover the size of the ventral hernia defect and coding for that. There's a really complex, equation there. I don't really use that, but this is what the adjacent tissue transfer codes look like. Now, it's really based off of soft tissue codes where you have a defect and you're using flaps of tissue to rearrange it, and you're billing for both the defect and the advancement as well. 3 things are involved with that. You need a donor site advancement and a separate incision, which, sure, there's no donor site here, but yes, you are advancing it. It's a separate incision, really thinking outside the box in terms of getting reimbursed. So how I do it. So for Reeve Stopas, I am billing 15734 times 2. Again, this is all very controversial, so take everything with a grain of salt. But that's also for open and robo. Our billers are really good with that because I have an ongoing conversation with them. Sometimes it gets reimbursed, sometimes it doesn't. For component separation, I'm doing 4 flap codes because I truly believe no matter what you're doing, you're creating 4 musculocutaneous flaps based off of pedicle artery. That's what you're doing in these codes. Rarely that gets reimbursed, but some insurance companies do. Medicare, United, some of our Medicaid plans, it's not much, but really those are the only 4 that I could find in my own data. So a very important thing is hernia incarceration. Now, there's a very stark difference in coding when you're looking at something that's reducible versus incarcerated. You have to remember that even though some patients see this on their summaries and they're like, oh, it was so incarcerated, what'd you do about that? It's really still just a coding definition and not necessarily should affect patient care. But in that regards, listen, I mean, if it was incarcerated at some point in time, you can call it incarcerated. If there's a small portion you can't reduce, technically it's still incarcerated. If there's a CT read saying as such, I mean, this can be very important over the lifespan of your career. I mean, this could be the difference of 4 RVUs sometimes. Codes we really should be using. So here's a benign tissue excision code, 1140X. Really anything that you remove from the body that's independent and takes its own time value away from the operation, that's not a tumor, benign, fat, skin, scar, calcinosis, you could potentially bill for this. Other codes we should be using, especially in groin cases when you're doing neurectomies, there are 2 separate codes. One's for a straightforward neurectomy, one's for a neuroma, specifically for a neuroma excision. However, these codes are very sensitive to ICD pairing, so you really have to talk to your billers about the correct ICDs to use. And let's say you're taking one of these nerves and reimplanting it into the muscle. There's a code for that. Nerve implantation onto the bone or muscle, a low RVU value, but it's reasonable because you are doing that separate work for a reason. A lot of my bigger abdominal wall reconstructions, let's say I have a large posterior flap defect, sometimes I can use hernia sac or scar to sort of patch that. There is a code for that, a dermafat fascia code. These are the very controversial ones when you're doing diastasis repair and paniculectomy. for my diastasis repairs, I used to include it in my hernia repairs, but then I tried doing it as a separate code, 22999, which is an unlisted abdominal wall code. Your mileage may vary drastically. I'm using a letter of medical necessity to bill for these, and sometimes they do get reimbursed. For a paniculectomy code, it's much, much harder to get these reimbursed because you need a lot more criteria to get them reimbursed, such as having the pannus hang below the pubic bone, rash underneath the skin, so on and so forth, but sometimes they still get reimbursed. So modifiers you should be using for these codes. So there's a difficulty modifier that's 22. There was a decently large study showing that it's quite controversial. Like you could bill for it and get some extra value, but you're more likely to get denied. But if you're doing a very complex, intense case, there's no way to capture that. Really, that's the only way to get reimbursed for your time. Separate procedure coding, again, controversial. Let's say you're doing a lysis of adhesions for 3 or 4 hours in one of these cases and you feel like you can't capture that. Sometimes they qualify it as unbundling, but if you really feel like you're doing the work, you can use a 5.9 modifier. Sometimes that gets reimbursed. Especially for 15734 coding, again, controversial. You really have to have a conversation with your billers because there's so much nuance to it. Some insurance plans only accept a 5.9 modifier, some accept a 5.0 for bilateral. But don't forget your visit billing. With these 0-day codes, you can bill for postoperative visits, whether inpatient or outpatient. And something we really don't think about is our office visit codes. If you're really spending the time with patients doing nutrition counseling, post-op expectations, and you're in there for 30, 45 minutes, you should be doing like level 4 or level 5 visit coding. Dictations, I'm not going to get into this because this is a whole hour-long lecture, but you really have to use some specific wording sometimes to get reimbursed. The good news is if you really don't get it right, your billers and insurance companies will let you know. And then another alternative is charging cash. So I do this rarely, but sometimes you sort of have to. You have to keep in mind that you are trying to get paid for all the care that goes into these patients. Diastasis and paniculectomy patients require a lot of post-op care and attention because these soft tissue reconstructions can be really complex and complicated, especially mesh removal for pain. I use an unlisted code for this. But I think the most important thing is being transparent with your billers. So this is something I get every month from Columbia. I get a list of the codes that I'm using. I get a list of what gets reimbursed, what doesn't get reimbursed, what bounces back. And I use that to sort of tailor which insurance companies I can use certain codes for, and so on and so forth. The other thing is collecting what you're owed. Listen, follow up with your billers. Send in your letters of medical necessity. Negotiate with insurances. Ditch other insurances which really aren't giving you, proper reimbursement if that's something you're into. But just don't be the surgeon. I'll read this here. I'm in desperate need of some help with code 15734. My doc wants to use this with every inguinal surgery that he does. His documentation does not support this. This is how those New York Times articles and so on come out. Just do not be this person. But in conclusion, borrow by a coding book, look at your own data, talk to your billers, don't do fraud stuff like whoever that was. We obviously need society buy-in. The AHS is working on it with a coding committee. Hopefully there's something out soon. And you can always ask me for help. Thank you.
That was great. We're going to hold off on questions till the end. Thank you. So next up, Dr. Michael Reinhorn is going to be talking about pros and pitfalls of establishing a private practice. Thank you.
Thank you all for having me. Can I do a quick audience poll? Who here is in private practice? Can you raise your hand? We've got probably about 3%. Okay. Anyone interested in private practice? All right. Another 3%. Perfect. Mickey Reinhorn, I've been in private practice. That's my only disclosure. I've run a small business for 23 years. I want to get your feedback on this slide. What do people here see? Get somebody shout out. Kind of, right? Here's the way I saw this when I started this, and I'm going to give this slide in another form later. Medicare has killed private practice in the way we know it. But I think value-based care is the solution. And so I'm going to talk about healthcare economics and healthcare finance. I'm going to kind of follow up on what Philip's talked from the private practice point of view. And then I'm going to talk a little bit about private practice and what it takes to succeed. We're going to start with that part first. So when I started practice 23 years ago, people told me you got to know the 3 A's. You got to be available. You got to be affable, likable, and you got to be able. Your ability came last. And you know what? 23 years ago, I put up my shingle. I got really busy with that. You didn't have to be any good. Now we've had to turn it upside down. You have to be clinically excellent at what you do to survive in private practice, at least in a metropolitan area. My feeling is that you cannot be clinically excellent if you don't love what you do. I'm an inguinal hernia specialist. I do roughly 500 inguinal hernias a year. I started as a TEP surgeon. I became an open preperitoneal surgeon. I've learned Schuldeis. I've done robotics. I've done it all, though most of it is an open preperitoneal, but I've become an inguinal hernia expert. I absolutely love what I do. I've also learned to draw lines. In that yellow box, that availability, you need to be available for yourself and your family. If you do not eat well, sleep well, and exercise, you're not going to be a great surgeon. And so I'll put in my public service announcement: to succeed in private practice, you got to do resistance training. If you don't do it 3 or 4 days a week, it's never too late to start. But go home after this conference and start doing it, because you will be able to practice for a lot longer. And then I think the most important part is the understanding healthcare economics. So let's see how Medicare killed private practice. So on the bottom is, in purple, what physicians get reimbursed. And as you know, Medicare kind of sets the rates. All insurances follow. On the upslope line is what hospital gets paid. And so over the last 23 years, the money has been shifted away from doctors to hospitals. And so what does that look like in real life? So I'm a patient of my own hospital system. Because of price transparency, I plugged in my own insurance to my own hospital on the left. On the right is Mass General Hospital. This is for an open inguinal hernia repair. My insurance company pays $17,000 in total. This is if you are an employed doctor working in my hospital system. So what does that look like in terms of the pie? 80% of the dollars go to the facility for the equipment, for the implants. 10% go to the anesthesia, and then 10% go to the surgeon, the surgical practice. In my case, I'm private. I get about $1,500 for a very good insurance company. I get $550 from Medicare, which I personally don't participate in anymore as of a year ago. My partner does. And then Medicare pays us $362 for a belly button hernia now with the coding change. Just for reference, I had a plumber come 2 weeks ago. We had to plant new grass seed and our faucet broke. And he spent 45 minutes, put in a $50 part, and I paid him $680. Okay. That's double what Medicare pays me to do an umbilical hernia repair. And then I got to pay my overhead after that. So for the hospital side, they clear $10,000. They collect $13,000. This is my cost. So Avant-Garde is a company that works at our hospital and looks at our implant costs, looks at our throughput, looks at how long patients spend. And it's roughly an average of $2,500 to do an open inguinal hernia repair at my hospital. The laparoscopic costs are about 2 to 3 times that if the robot is being used. But that means my hospital has a $10,000 contribution margin to then go pay their overhead for their CEOs, for the lights, for the air conditioning. Me, on the other hand, I have to live. This is the profit and loss statement for my practice for the first 7 months. We have 2 surgeons and 2 PAs. On the top right, we collected $1.1 million. We do roughly 1,000 hernias a year. So that 1.1 comes out from consults from a variety of insurers. And a year ago, I made the switch where my personal practice is 40% direct pay from employers and patients. And that's on the bottom, some of the bundle services. But on the left, when you look at that pie, out of that $362 that we get paid for an umbilical hernia, 49% of that goes to the doc. So about 180. Sounds kind of painful, right? So you have to change the equation. So we looked at value, and how do you define value? First, you look at quality. I do sit on the board of the ACHQC. I think you can only look at, you have to examine your own data. Ideally, you compare your data to others around you, and you learn where you can do better. You learn where you're doing pretty well for yourself. And I've reported 2,400 patients into the QC over the last 7 years. We've published our outcomes. We kind of look at where the outcomes are, but this is the part I meant about being clinically excellent. We all can do better, and I continuously learn. I still remember looking at my data and Ben Paulos telling me, you can't use Ethibond to suture your belly button meshes. You got to use an absorbable suture. And you know what? We've had less mesh infections. So we can always get better. But how do you create a bundle, and how do you do it competitively priced? So I'm not smart enough. I've used technology. So the technology used is called HealthMe, and we've created a little network for hernia surgeons called Hernia Connect, where we're connecting employers with a surgeon that can do an ambulatory hernia repair at a lower cost. So for this case, I do it for $7,600 for an employer. If you're a patient, we do the whole bundle for $7,300. I've had to negotiate with my anesthesia group, with the surgical center. I've done it at 2 different states with 2 different centers. But we have a competitively priced bundle. So what does that look like for an employer or a patient shopping for healthcare? So on the left is a traditional model that exists today for 97% of people. And on the right is where I see the future of healthcare going. It is no secret that the system is broken. And I think we have, through necessity, have to innovate and fix the system internally, because no one's going to do that for us. And so what we've done is we've shifted the dollars to the actual surgeon cutting the patient open away from the facility, and we've reduced the price at the same time. And so I'll go back to that introductory slide. If you get really good at what you do, if you love what you do, it's pretty easy. Everything else kind of follows, but you have to be understanding of the economics of what you're doing. So if you don't know what it costs for your hospital to do your procedure, you should look at it. You should also look at what the hospital is getting for their reimbursement piece of it. This is the way I kind of look at this slide after giving this talk, is you can name all the variables that are hurting our healthcare system, but I think innovation in private practice is one of those unique opportunities that we have to actually impact the system from within. So I want to leave you with hope. Private practice for the 3 people here and the 3 people interested, it's absolutely not for the faint of heart. You work your tail off, but I think you really have an opportunity to pave your own way. There's not a lot of us inguinal hernia specialists out there. A lot of people are abdominal wall reconstruction specialists, but I've got a very unique niche. I love what I do. I love teaching it. And if you're interested in learning more, just scan the QR code. You can download my V card with it. And I'm happy to answer questions later on. So thank you.
That was fantastic, super insightful. The next we will have Dr. Greenberg, who is at Duke, giving us a talk on improving diversity in hernia surgery.
So thank you guys for the introduction and the opportunity to speak. These are my disclosures, really not relevant to the content of this talk. This, I actually think, is one of the harder talks I've had to create or give. Clearly, I am a white male. I am about as undiverse as one can be in every characteristic. And I grew up in an upper class family with a lot of privilege. And I think I have not ever had to walk a mile in anyone else's shoes or go through a lot of the challenges that many people sitting in this room, sitting in rooms everywhere, and sitting in the world of surgery have had to go through. And so in thinking about how to put this talk together, I haven't really experienced any of that personally, but I have been married to it for about 20 years now. This is my wife, Caprice Greenberg. She is the chair of surgery at the University of North Carolina. And over the 20 years that we have been together, I have trained with her. I've been a partner in the same department as her. I worked for her for a year, both at home and at work. And now I am at a different institution, and through all those different phases of our life and her professional career, I have watched the difference in the way that the two of us are treated based strictly on our sex. I have had a lot of privilege and a lot of things happen to me that just don't happen to her because she's a woman. I am spoken to differently by people. I am treated more professionally by our nursing, by our ancillary staff, by many of our patients. And even today, as a chair of a major academic department of surgery, she comes home real pissed off when people mansplain stuff to her, which happens all the time. And I am very careful not to do that at home for fear of my own life. So, I mean, this is very clearly the difference that probably 50% of the people in this room experience on a day-to-day basis that we as white men don't. And it's been something that's been very eye-opening to me over the course of my career. Now, I think you could take that and use, I'm using women in surgery here as just my easiest example because I'm married to it, but it certainly applies to everyone that's underrepresented across every possible demographic. And it's probably worse for people who are underrepresented in terms of race, ethnicity, and certainly at the intersection of those. Black female surgeons, I think, have to deal with dual challenges compared to white men. So I think in terms of how we improve diversity in hernia surgery, to me, in thinking about this, I think a lot of it has to do with sponsorship, opportunity, and representation. So sponsorship is different from being a coach or a mentor, right? And I really like this slide. A coach talks to you, a mentor talks with you, but a sponsor talks about you. A sponsor is someone who goes and puts themselves on the line to elevate you in professional organizations, provide you with opportunities, and seek to improve your own career. But it also should be a beneficial relationship for them. This is a great article called How to Do Sponsorship Right. It was published in the Harvard Business Review. And in this, they talk about the types of help in developmental relationships. And this is not something that happens overnight, right? I think many of us who work with residents and medical students, we often are viewed as their mentors. We privately give them advice if that's the case, right? If your relationship continues to develop, you can be a strategizer where you think about their professional career and give them advice about how to advance about it. You can be a connector where you take them around at meetings and introduce them to key figures so that they can have opportunities to meet them and again, further elevate themselves. You can be an opportunity giver where you seek out high visibility roles or projects for them. But most importantly, you can be a sponsor where you're really committed to them over the long term through all of those attributes. And when you do that, you move into that far upper right quadrant where it's really authentic sponsorship, where the sponsor is really looking out for the benefit of their mentee over the course of their career. And I think that's what we should all strive to do for people who have less advantage and less opportunities than ourselves. This plays out particularly in professional societies and organizations, right? So on the right side of this slide, you see sort of the career pathway of advancement that you want to see when you join a professional society, right? Someone tells you you should join AHS. So you sign up, you see that there are some committees that you want to join, you start doing some committee work, you get known to people outside of your institution by working on those committees. If you do enough good work, hopefully you advance in the society to the board or to the exec level, and that helps to further advance your career. Unfortunately, on the left side, we see what happens actually with female physicians in the United States, right? So 97% of them think that they should join an organization, but only 50% end up doing it. And then the numbers continue to constrict further down as they try to get to higher levels within that organization. So it's the opposite of what we want to have happen. In AHS, we are 22% female. We are 3% Black. We are 14% Hispanic, and that's, I think, actually an excellent representation, largely due to the Central and Southern Americans that we have in our organization. But clearly, we have some work to make our demographics look a lot more like the demographics of the world of surgery, which is where we should be. A lot of that opportunity can happen at meetings like this. All right, so this was a nice study that looked at 8,535 sessions over a variety of different conferences, nearly 100 medical conferences. Women accounted for a third of those speakers. More than a third of them were manels, men-only panels. Only 6% of those were women-only panels. And about 96% of conferences had at least one male panel. That's nearly 100%, and that is not okay in this day and age. Interestingly, specialties associated with lower baseline female physicians tended to have a higher proportion of female speakers, which is a little bit contradictory to what you would think. But I think one of the things that happens is that there was a very strong positive correlation. If there's a high proportion of women on planning committees, then they select women to represent them in those speaking conferences. So we should have underrepresented people on all of our program committees and to help plan organizations and studies. I don't know what was being discussed at this manel on the Global Summit of Women in Paris, France, but this should not happen. When you also look at the amount of awards given to underrepresented minorities, this is again looking at women in organizations, there are a lot where it is zero, right? So this is the humanitarian awards, the Tipton Awards, like at all the different organizations. Most of us have awards that we give out, and unfortunately they go to a lot of the majority rather than minority. So in looking back over the last several years, AHS, we've had one female president, Dr. Gina Adralis. This Dr. Ramaswamy is our second. And so the only female presidential address we had before this year was in 2019. We have had one other female keynote speaker. She was my wife. She is not a hernia surgeon, I will point out, but she is a breast surgeon and a leader, and she spoke about surgical coaching. But she was our one other prior keynote speaker. And in the last couple of years, we've had a lot of male speakers holding these kind of key addresses. This year, we had a female president, and we had a female keynote speaker, and that female keynote speaker highlighted a DEI concept, right? And so that is how we raise opportunity and move our society forward, by making it front and center in the form of our keynote addresses. When we look, we do have an actual award that focuses on female factors in hernia, which I think is a good thing. And then unfortunately, when we look at our Nihus Once past award winners, they are 100% male. That does not mean that they are not deserving of this. They certainly are. But I would also say that Dr. Adralis is very deserving of this as well, right? And she should certainly be on that list, as are many other people in this room and in this organization. So we need to do a better job of this. My life lesson on representation happened through Callistus Dita. Callistus was one of my residents when I was the program director at the University of Wisconsin, and has had a real impact on me as a human being. Callistus was born in Cameroon in an impoverished village. He actually had to flee his village after some political strife for his life, so he was homeless in Cameroon for a while. But he was very intelligent, and that was identified early in high school. And so he was sent to live with his brother in Minnesota. So he immigrated to the United States in high school, was working at McDonald's, and eventually went to a community college in Minnesota before transferring to the University of Minnesota, and then going to the University of Michigan for his medical school. We were very happy to recruit him to our residency program at University of Wisconsin. And I took over as residency program director right when he was finishing up his third year. And the assessment on Callistus at the time was that he was behind technically, and that we thought he needed to extend time in training to catch up. And so I sat down with Callistus, told him this, and sort of tears welled up in his eyes, and he swallowed it down, and he just said, whatever you think I need to do, I will do. I have faith in you, I trust you, and I'll do it. And so we had him repeat his third year. And during that third year, we had him spend a month in Africa. So he went to Ethiopia and he did a global health rotation. And he came back from that a completely changed resident. He aced the ABSITE. His technical skills developed. His leadership skills developed. Like something just clicked. And so at the end of his third year, I sat down with him again and said, Callistus, like, one, we're advancing you. You're doing great. But what happened in Africa? And his answer to me was, I saw Black surgeons operate, and he had not seen that before. And to him, he realized that that was a potential future that he could now see in his present. And it had meaningful impact for him. He went to the University of Washington for his CT fellowship. He is starting on faculty right now at SUNY Upstate. And I am confident that he will be the representation that he needed to see to be great himself, and will be a role model to young residents as well. He's really an incredible human being. This is our representation. So we do have some female leadership, which is great. Hobart Harris is an African-American. I think that's excellent as well. So we do have some representation, but I think we have to be mindful about people that we put up for these positions and make sure that we continue to help with that representation. this is how it looks across the pond, right? Certainly, there can be some opportunities for more diversity at our leadership of our organizations. So I think to improve diversity in surgery, we have to be intentional. We have to be thoughtful about it. We have to speak about it. And more importantly, we have to act on it. And so all of you in this room who go home to your institutions, be the mentor to the people that you need to be and help to elevate them at work and in your societies and certainly here, because we need a better mix. Thank you.
Thank you for that great talk. Next up, we have Dr. Greg Dumanian, who will be presenting on academic careers in hernia surgery.
Thank you, AHS, for inviting me to give this relatively personal talk. Last presentations have been great with lots of numbers, and going in academia, all of a sudden, there's a lot less information that you have, and I think that's unfortunately going to come through. In terms of diversity, which is a huge topic in my plastic surgery residency, of 17 residents, 11 are women. So we're trying to walk the walk and talk the talk. And of the people up front, 2 of your 7 are Armenian. So it all depends on your sample size, I think. Let's see, how does this? Hello? I did. Yeah. All right. So a conflict of interest, I'm the medical officer for Mesh Suture Inc. Might have a little bit just personal references of my academic career. So what has been my career? I'm a little bit of an oddball here. I'm one of the 2 plastic surgeons that I know of, no, 3 that are in this meeting. Went to the University of Chicago Medical School, Massachusetts General for surgery, Pittsburgh for plastic surgery, and then I did a hand fellowship, and I've been at the Feinberg School of Medicine down the street since 1996. There's tons of overlap. Everything I say is going to be sweeping generalizations because there's so many models of how we can live our lives. Pure academic, that's where I am. Pure private practice, which was what my father did and which we heard so eloquently earlier. And then there's these hybrids, the Mayos, the Geisingers, the integrated medical centers that are large, maybe or maybe not affiliated with the university, maybe or maybe not with residents. And so categorizing this huge middle group is essentially impossible to do because every situation would be different. I'm talking about the pure academic life where there's a high complexity of cases, there are research opportunities. Collaboration with colleagues can happen in any of those work groups. But maybe in the academic life, especially where you have a team within your division, may be a little bit enhanced. Teaching is definitely one of the pillars of why we're in academia. Work-life balance has been touched on, and then professional development. So that case complexity is, I think, sweeping generalization greater in academia because you need teams of people to help take care of patients with severe comorbidities that still require surgery. The challenges are stimulating. I mean, that's why we did all of our training. I think we all come home after a, quote, great case and are exhilarated by the experience. It makes our skill set seem that much more special and unique, though we're not unique, we're all replaceable. But at that moment, after that great case, you do feel relatively special and unique. And it builds this sense of resilience. I got through that case, so I can get through this case, and I can get through the next case next week. And what's the opposite of resilience? I mean, there are lots of definitions for resilience. I'm not sure all of those apply, but I think we know resilience when we see it. We overcome a challenge, and then there's a new challenge, and we don't shrink from that. And then we take care of that, and we go over the next hill and the next hill. So, but maybe all of this case complexity is not desirable. More complications. I got texted with 2 or 3 complications down the street during this conference already. Too much variability in our lives, hard to plan, unpredictable timing. If I have to, as a plastic surgeon, I'm closing a spine wound that all of a sudden it goes on at 8 o'clock at night. And I need help from other specialists. I have a patient who needs a, cath right now. And if we're getting an RVU for a particular procedure, does it really make sense to spend extra time to do all that work for the same RVU? That's the book of duh. Why are we doing this? So what gets you excited? And this is the exact words were used earlier today. What gets you excited to go to work? What are your priorities? It's not my priority to take care of this patient, but it is a privilege and an honor to have a skill set that people have given to me to be able to say, I can do this case. Patients with bad hearts, bad livers, bad kidneys, transplant patients, the morbidly obese, the contaminated. This patient was on my schedule to have a hernia. And then I got a call from the transplant group. They're like, hey, we're doing a liver. What should we do about your hernia? I was like, oh, geez, stay above it. And then I'll work below later on. So she had her successful liver transplant, and then we did her hernia. This is academia. It's crazy. Why would anybody want to do this case? Or that one. My average BMI is, 32. This lady was 45 with a bowel obstruction. How's it going? So this was an Iowa farmer. This is why you do it. These opportunities. This is one of my rabbits. I'm a peripheral nerve specialist and with amputees and playing with phantom limb pain, et cetera. And so we created this model of a three-legged rabbit to learn how nerves respond to amputation. It took many gifts to the veterinarians to get this through the IACAC. And about 10 years later, we came up with this. This was from 2012. This was my daughter's capstone for high school. And, I went to Michigan. I went to the resident who was doing this animal hernia model of Michael Franz. You may remember that name. The resident taught us how to do it. And then we started creating these little rat hernias to understand the issues of suture pull through and sutures tearing through tissues. That's a balloon and a cadaver. And then I had some mesh from a hernia case, and I made these little mesh strips, and I put that in a balloon, and all of a sudden the balloon explodes not through the incision line, but somewhere else. So then, you have access in academia to these animal labs and IACACs who can let you do animal experiments. And so we created these little rat hernias and then closed them with either a mesh strip, which I'd taken the mesh from my operating room, or a little Proline. And lo and behold, all of the mesh strips stayed intact, and 65% of the hernias done with sutures fell apart. So that led to this. So much fun. How can you have this much fun as an academic to have an idea and to work for 12 long years and then to get to something that all of us can benefit from? So these research opportunities, unfortunately, keep getting harder and harder. The bar keeps getting higher to get NIH funding or Army, DOD funding. And in the meantime, you're writing up case series and book chapters and doing RCTs and R01s and industry studies. The bar keeps getting higher, and yet the journey is worth it. It does take nights and weekends. We've talked about the work-life balance. So this is a porcine abdomen. But if you notice in the upper right, there's some weirdo design. That's my kitchen table. And so I did this on the kitchen table and, took lots of photos of it. Lots of collaboration and partnerships that are tons of fun. One was in India, the other was in Denmark and Copenhagen. But this is what it's all about. A couple years ago, all my residents were together in Boston. I missed a hand society meeting, and then this is what I got, telling lots of Greg stories. And all of those residents went into hand surgery. Talk about feeling good. And this is actually one of my prized possessions. This person who I don't know from Ohio State was writing to her mentor saying, I just hope my residents will talk about me like you talk about Demonian. I mean, nothing can make you more happy to have been an academic despite all the challenges, all the problems with lack of control. I don't know my numbers. I do cases and then something happens on the back end. I mean, that's crazy. I don't set my own salary, whatever. I have commitments at night for visiting professors at journal clubs, and I get calls all the time, and my life is not predictable, but man, it's a lot of fun. So yeah, you do the societies, meetings, leadership roles. I do as little as that as possible. I like operating. I like being with my residents. I like pushing the boundaries of surgery. I titrate all that other stuff. So looking back, I'm the most senior person in all of Northwestern Department of Surgery. That's weird. I'm glad I didn't move or leave. There are warts on every job. And then when it's right on your nose, it looks really big, but every job has warts. I've trained 56 plastic surgery residents in my career, and I've overlapped with tons and tons of all of those other types of residents. And I wouldn't have been able to accomplish what we've done to help all of our patients if I hadn't been an academic. So with that, it was at the expense of my family on nights and weekends, and I'm trying to make it up right now. Thank you very much.
Thank you so much. Our last speaker will be Dr. Yuza at the University of Wisconsin, who will be talking about landing your first job, contracts, and more.
Awesome. Well, thank you for the panel to give this talk. I appreciate it. I always love coming to AHS. A lot of similar-minded folks and some great topics to discuss. So, as mentioned, I'm going to talk about looking at your first job, contracts, and more. That is the title of my talk. I'm an assistant professor, director of hernia surgery at University of Wisconsin. Excuse me. I do have some disclosures. The only one relevant is that I have a contract and it pays me. I am therefore biased about getting paid, but on Wisconsin. So contracts and more. We'll talk about a little bit of what's important in that. What's a letter of intent? What's in a contract? Why is it important? What you can negotiate and what are some red flags? We'll try and go through some of this. There's a lot when you talk about contracts. Contracts end up being many, many pages. And if we went into all the details of that, we'd be here for several hours. We're going to hit the high level and hopefully hit the big parts that people, that cause people to leave a job. All right. So contracts, I want more information. We've all been trained. You want more information on a topic? What do? You go to PubMed. All right. Physician non-compete, no results. Physician compensation, no results. Malpractice, contracts, nothing. All right. So that's just to say that there's not a whole lot of high level scientific data on this. If you want information on this, you got to talk to people. You got to go to some of the alternative sources, and they're out there. So a couple of sources you can look online, Facebook groups, online groups, and these can give you the information that you need. Okay. So where are you? You are, if you're looking for your first job, you're a career newbie. Okay. You got through a residency and a fellowship. How did that go? You ranked a place that you interviewed at, they ranked you, and then a computer decided to spit you out where you're going to go. You didn't really have a whole lot of choice. You just put your nose down and got through it, okay? Now you're on to your first job. You're going to get a job offer. You're going to negotiate with them, but ultimately you get to decide. No pressure, right? How does that look? Well, it usually starts with a letter of an intent, okay? What is that? It's basically just a good faith agreement between two parties, okay? They agree to consider you for the job. You agree to consider the job, and you both agree to negotiate on a contract. What it essentially means is both sides are going to kind of pause looking at other opportunities so that you can work towards this. And they're not going to try to slide a candidate in, underneath you, and you're not going to try and do the same, okay? What it shouldn't be and what you need to watch out for. A letter of intent should be non-binding, okay? If you can't come to terms with the other party, you both need to have the ability to walk away, okay? And that should be stated, all right? But be aware that it can stipulate some key components of the contract, okay? Things like the salary, all right? So if you sign a letter of intent for a job that pays $300K, if you get to the contracting standpoint, they may say this was the salary that you agreed to on the LOI. And that's what we were planning on. Okay, so it makes it a little bit harder later on. If you apply for a 1.0, that's a full-time 100% FTE job, and then you later decide, you know what, I'd rather be a half-time, that really didn't fit what they were interviewing for, and they said you signed a LOI that was a 1.0. So if we can't agree on that, then we're gonna have to move on, okay? It can also stipulate the location. If you want to be at their downtown, but on the LOI it said you're gonna be at their regional campus, that may be outside of the scope, all right? So you need to think about those things before you sign the letter of intent. But again, it should just be a handshake, good faith agreement. Moving on to the contract then, all right? This spells out the high level stuff, the most important parts of it, okay? It's gonna detail duties and obligations, compensation, it's probably the first thing that we all think of when we think of a contract, restrictive covenants, which can be very important, malpractice, and then renewals and termination. And this is what they look like in the bottom right corner, all right? A whole lot of legalese, bunch of whereases, and now therefores, and hereunto for, otherwise known as, all this stuff written by lawyers. We read Latin pretty well for medicine. They speak a whole different language, all right? So as you're reading through it, just be careful that you understand what's going on. And why is your contract so important, okay? Because, you know, this, all right? It's shown that most folks, 50%, I shouldn't say most, 50% leave their job within the first 5 years. And I think that's a lot of that is because you just don't know what you're getting into. You have an idea of what kind of a practice you want, but all the details of it, there can be some disillusionment when people and the parties don't, you know, aren't seeing eye to eye. It's easy to leave, or easy to want to leave your first job. That's why you don't see a whole lot of, you know, first boyfriend or girlfriend or significant other making it all the way, right? Because you just don't know what you want at that point. So you learn as you go, all right? But let's learn about some of this so that you can at least go into it with some information. So outlining your duties and obligation. Here we go. This is one contract that we looked at. Your practice will be located at a determined outpatient location with inpatient call at one of our hospitals. Not a whole lot of detail there, okay? And I would tell you that this contract did not work out so well, all right? Well, here's a different one, all right? You'll be assigned 1.0 FTE and report and be accountable to the chair. Okay, all that sounds normal, or his or her designee. I don't know who that is. All right, division chief, sure. You may be assigned clinical, administrative, or teaching roles and or research responsibilities, so on and so forth. I like this, as assigned by the department chair from time to time. All right, well, so it basically is more words, less meat. It basically reads the same as the top one other than spelling out the FTE. So, all right, well, good. They cite Exhibit C, and there's always exhibits. Exhibit A usually has the salary and compensation. Exhibit C often has the duties and obligation. So let's turn to Exhibit C. None. All right, well, so what should you be looking in for duties and obligations, okay? You do want to know what your FTE appointment is going to be. If you're thinking you want a 0.8 or a 0.7 FTE and they're planning on 1.0, you're going to have a misalignment in how much you need to be working, okay? You want to know what's your, if this is an academic job, which by the way, most of this is geared towards academic medicine, or what academic track are you on? Are you on a tenure track? Are you on, you know, are you clinical health? They have all these breakdowns, okay? So understand what your roles are. You looking more clinical or you're looking more academic, all right? And that also goes along with what are your academic appointments, all right? If you show up on day one, they go, hey, you're the residency assistant program director. You go, okay, great. We get voluntold to do a lot of things. Some of that should be clear to you, okay? Especially big things like a APD role, okay? Because that's time intensive, okay? Where you're gonna be working, which division you're gonna be in, this is always a hot one. What call are you covering, okay? Again, going back to voluntold, calls got to get covered, all right? And if you've got 10 people in the pool, not so bad. 5 people leave, and now you got 5 people in the pool, that's going to get kind of challenging, okay? So having some understanding that, and how is additional call going to be handled? Are you going to be compensated? Because I can tell you working an additional call hurts a whole lot less if you're getting something on your paycheck for it, okay? You shouldn't be expected to do a lot of free labor. We do enough of that. All right, compensation, another hot one, okay? You want more of this and less of that, okay? And I'm going to tell you that the dollar amount doesn't necessarily matter, okay? If you feel you're being well compensated for the work that you're doing, okay, even if you're making less money, you can be on your left screen there, okay? But if you're doing a lot of work, even though you're making a high salary, but you feel like you're getting the short end of the stick, you're going to feel like the right there, okay? So having a good understanding of what you're getting paid for. All right, compensation, we always think about just salary. It's not just the salary, okay? That's the baseline number, but they'll also include in their taxes paid for you, bonuses, sign-on contributions, or sign-on bonuses too. So work bonuses and then sign-on bonuses, or maybe student loan repayments, insurance, disability, retirement contributions, and pension, okay? Salary, you know, sets to be a number. I could tell you that jobs can significantly go up or down on the rankings based on these starred items, okay? You can have a job that pays a modest salary but has great retirement, pension, and retirement contributions. That can significantly increase, okay? So don't just look at the salary, look at the overall compensation and what they're doing for you in addition to the salary. When you get to your contracts, they're going to cite a bunch of data, MGMA data, AAMC data, okay? They're going to have this because they're doing a lot of contracts. You have to pay for it, okay? They're going to use that as a benchmark, all right? You can pay for this if you want. We'll talk about contract lawyers a little bit later. There are alternative sources. This is a self-collected data, not me, but within this community. So you can get an idea, okay? At least they're not going to use this as their benchmark, but you're going to at least know, are they really lowballing you? They can say you're at the 50th for the MGMA. You'll get some idea of that, okay, based on alternative sources and be able to come back at least. In my specialty, with what I do, here's what a lot of people are making. I think we should be closer to that. Your first job, they're taking a risk on you, so don't expect the 70th percentile, typically 50th percentile even. They'll start you typically at the 25th, somewhere in there, because they're taking a gamble on you too. As far as compensation goes, you want to know, typically there's a guarantee involved, especially when you come out. How long is that guarantee? Okay, is it 1? Is it 3 years? All right. If you plan a slow increase in your clinical practice, you probably want a 3-year guarantee. If you plan to come out of the gates doing more clinical and less academic, can I transition out of that to a performance? Okay, if you're locked in a 3-year guarantee, but you are ramping up your clinical and you're bringing your hospital a whole bunch of money through your clinical work RVUs and things like that, you're going to feel like you're getting shorted because you're not seeing that money. They're just paying on you on your guarantee. How are you paid? Is it RVUs billed versus collected? That can differ significantly. All right. And what metrics, goals are you working towards? Do you have a set number of RVUs? Do you just have a set number of patients you need to see? All these are important. All right. Also, citizenship and opportunities for advancement. So citizenship is, you know, do you attend, and this is in academia more than private practice, but do you attend M&M? Do you attend grand rounds, things like that? What are your opportunities for advancement if you want to increase your compensation? Withholds, they've been written into a lot of contracts, have been written into a lot more after the pandemic, okay? The department wants to kind of protect itself if clinical volume drops off like it did in the pandemic. So a lot of places will have a withhold. They withhold, I've seen anywhere from 5 to 10%, upwards of 20% of your salary, and they'll give it back to you later as long as everything goes good, but they're protecting themselves, okay? That can be a big chunk, so just know about that. Sign-on bonuses and loan repayment, they love to dangle this, and I don't say this nefariously, but they love to put these out there for new graduates, all right? You're broke, you just got done with a residency, you probably have student loans, all right? Here's a big sign-on bonus, all right? Come with us, and it'll all be great, all right? That's good, fine. How much is it, and what is guaranteed, okay? Who is paying the tax on that? Because $100K sign-on bonus, you'll probably get $50K of it. What is the payback schedule, all right? A lot of times these are tiered to how long you're there. If you are, and they can be anywhere from you've got to stay 3 years or you pay 100% back, or if you stay 3 years, you have to pay back 30% each year that you don't stay there, okay? And that can be pretty big when you're looking into, if things aren't working out and you want to make a job change, you know, coming up with 20, 30K is a lot of money, all right? Restrictive covenants. This is always a big one, the non-competes, all right? What is it? The intent is to protect the employer. Bringing on a doctor, bringing on a surgeon costs the hospital, they often cited numbers 1 to 1.5 million, okay, because they're investing in you. What they don't want is for them to bring you on, you build up a big practice, and all of a sudden you go to the competitor down the road or across the street, all right? But it does feel like it's a restriction to your right to work, all right? They're protecting their investment in you, but you've got the brain trust, you've got the brain power, you've done the clinical work. And if they say you can't work anywhere nearby, what that's going to result in is you may have to move, all right? Especially if you're doing academia, there's not a lot of places that may do or have what you want. So I'm going to speed it up. I'm sorry. I know this is going long. This is just an example of restrictive covenants. Okay. This one reads that you can't practice anywhere within 10 miles of your primary practice. Okay. And this is important. So what you need to know is the range, 10 miles. Okay, fine. From where? My primary location or all locations? All right. With some of these big health systems now, you can have health systems all across the state. All right. And if it says all their locations, you may be moving out of that state. All right. If it says just your primary location, which is the majority of them, okay, you've got to be 10 miles out of that. But just know this can be a sticking point. All right. What is the duration for that? Some non-competes are 1 year, sometimes it's 3 years. What's your contingency plan? Okay. All this can leave you with a bad taste in your mouth. If you feel like you want to leave, take everything that you've learned and all you've invested in yourself, and you feel like you can't because of these restrictive covenants. Well, I would say fortunately, unfortunately, help was on the way. In April of this year, the FTC came down and said non-competes are going away. They cannot be enforced. That was great. People were just waiting for everything to final rule in law, and then every physician's non-compete would go away. Unfortunately, in August, the United States District Court banned that basically. So they dangled it in front of us and took it away. So we still have non-competes. A lot of us, many of us do. I want you to know about them, and we'll talk about what you can negotiate later on. Malpractice is another big one, all right? They want to pay you, or they want to do a claims made. You want occurrence-based, okay? What's the difference? A claims made covers you in the lawsuit if the lawsuit comes while the policy is in effect, okay? It takes typically 1 to 3 years to generate a lawsuit after an event occurred, okay? My wife is an OBGYN. 18 years after delivery, she can still be sued, okay? If you have a claims made policy and you want to leave from hospital A and go to hospital B, somebody's got to cover your tail or cover you. Otherwise, if they sue you in 5 years, you're uncovered, okay? You're exposed. So you want occurrence-based. That means you're covered if the event occurred while the policy was in effect, okay? So the hospital's covering you. You have a policy that's occurrence-based. The event happened at that hospital. You are covered in perpetuity, all right? If you don't have that, if you don't have an occurrence-based policy, then you need some tail insurance if you need to leave the job, okay? Question is, who's going to pay for it? Sometimes they have a structured or a tiered basis for paying for it. If you stay for 3 years, they cover your tail. If you stay for 2 years, they cover half your tail. If you stay for 1 year, they don't cover any of your tail, all right? You need to know that, okay? Because to buy your tail insurance, it can be 5 to 6 figures. This was ortho, but you see the disparity there, all right? Coming up with $300,000 just to leave a job to pick up your tail insurance. That can be hard, all right? And if you're young and new, coming up with that kind of money can be pretty, they can be rough, okay? The alternative to tail is nose insurance, okay? Nose insurance is you're going to go over to hospital B, they can pick up your tail, and it's considered nose insurance, all right? They pay for it. Reality, you're still paying for it because what they're going to do is just reduce your sign-on bonus, salary, whatever to compensate for the cost of that nose insurance. They can usually do it cheaper because they've got a policy already for the rest of their insurance, so they'll just roll it in there. But again, you're paying for it, just you don't see it. All right, so again, physician contracts, we talked about what's in there. A lot of times you're going to hear from them, well, these are our boilerplate contracts. Everybody in our big academic center has these same contracts, and everything is tiered, and we have no room to move on it. There are ways to negotiate. There are certain things that are harder to negotiate, some things that are easier, okay? Harder, you'll see compensation on both sides, okay? Because the parts of compensation can be The salary may not be. They may say, we're going to pay every new surgeon fresh out of practice at the 25th percentile MGMA data, all right? But you may be able to negotiate the other parts of it, sign-on bonus, loan repayments, so on, okay? Malpractice, usually, again, a big hospital will have the same policy covering everybody. Non-competes, we like to say you can negotiate around a non-compete. Again, they want to keep all physicians on the same track. So it's sometimes hard to negotiate out of that. Duties and obligation, benefits, FTE, things that you can negotiate and can make your life significantly better. OR access. If you want to be very clinically active, all right, and you want to get your productivity up there, you better make sure you have some OR access, okay? If you want to be a robotic ab wall surgeon, you better make sure they've got a robot for you waiting, all right? So you can build that into there, right? Because they want you to be successful clinically. You want to be successful clinically. If you're more academic, you can talk about research funding to get your research off the ground. I talked about sign-on bonus and loan repayments, also duration. You can negotiate that. Admin time, CME, start date. If you're coming out of fellowship, if I have one bit of advice for you, take some time off. It's your only time in life where you can get 2 or 3 months and enjoy life again after a very rigorous residency. All right, and also get it in writing because if you get a little word of mouth, it may not be enforceable. Okay. Should you use a contract lawyer? This is real quick. I'll tell you my 2 tales of using contract lawyers. The first one was relatively inexpensive. He offered to review our contract for us. He did so, but then ghosted us until the last minute. We had to keep emailing him. He passed back. He said he looked at everything. It was perfect, no problems, wouldn't make any suggestions, promptly cashed our check. And then we learned that we had a claims made policy that didn't go into effect for 3 years. So we ended up picking up a tail insurance policy. Well, actually, it was a nose. The new employer picked up a nose for my wife. The other one was more expensive and agreed to go through everything. We had 2 meetings, and then he timed out apparently on his somewhere in his paperwork. It said, I will put this many hours forward. And if you want more than that, you are going to pay me a lot more. We are the only profession where you feel like you should keep working until the job is done. We don't just log out at 2 hours, 3 hours. So anyway, their range can be $5,000 to $5,000. Okay. I haven't had good experiences with it, but if you are really concerned about it, it may be worth consulting either a mentor or a contract lawyer to look at that before you sign on. Red flags, unnecessarily vague contracts like that first one that we showed. You'll work somewhere when we say, when we want. Unwilling to negotiate on anything. Okay, this is our boilerplate contract. You sign it or that's it. Overzealous in the non-compete or overly restrictive. Large sign-on bonus with a long repayment. We'll give you $100K, but you got to repay it if you don't stay here for 5 years. You know, so consider those things. And then a long time to tail. Remember why we do it. That's it. Sorry, I went long, guys. In my head, I think I talked a lot faster.
Thank you so much to our wonderful speakers today. We will start with any questions from the audience.
Hi, Sharon Tofi, fellow private practitioner. For Dr. Dumanian, I'm curious how you were able to build your company and come up with innovative ideas while being employed.
The ideas are an outgrowth of clinical practice. The most or many universities will have an innovation tech transfer office where they give you 2 options. They will take your idea, they will pay for the patent, they will find someone to license the idea, and you get a percentage royalty. In my case, it's something like 16 to 20%. Or they let you create the company. You are the licensor of your own idea back from the innovations office. You have to then pay for the patent. You take all the risk. You get the majority of the benefits other than a certain percentage of negotiated sales that go to the university. And, You know, it's all the risk, all the benefit, or no risk, you have an idea, you give it to the innovations office, and maybe they will license it to somebody. And it's just nights and weekends, though.
Hi. My name is Sierra Grasso. I am a current fellow. I am actively in pursuit of my first job. So I was curious if anybody has recommendations on the best way to go about doing that and finding. I've looked at platforms, Doc Cafe, recruiters, things like that. But if there are any good recommendations of ways to go about that, that would be great. Thank you.
I would also say, I was going to touch on it in my talk, but clearly went too long anyway. AHS and ACS both have job posting web boards. All right. So go on there. If you join any of the physician advocacy groups on Facebook, a lot of times you'll see people post, hey, we're looking for this or that. So that's a great outside source. And then, you know, just talking to your mentors or mentors and those who are working with you, you know, because oftentimes we have an idea who's looking, who's going to be looking, what's coming up or coming down the pipeline.
And decide where you want to be. Number one. Number two, of those models, pure private, pure academic, somewhere in the middle. If you could live with all three, makes you more flexible. But key is location, 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 and then zero in with your mentors of who they know in that area, who could then spread the word that there's a fellow that wants to live in the Midwest or Tennessee or wherever.
Hey, I have a question for Dr. George. This is specifically about your CPT coding and how you're altering them for various insurance coverages. Where in your workflow is that? Do you have like a little note card for yourself or something on your phone? Like, how are you keeping track of, you know, the 12 different insurance coverages and which one you're going to be altering your coding for?
That's a really good question. Usually it's off of me now. I've had like extensive discussions with our billers and they're like pretty smart about it now, but I don't really do different sets of billings for different insurance companies. It's those random modifiers that are the most important things. And luckily I don't have to think about it because our billers have all that stuff sort of saved in their memory bank. Pretty easy. I have another comment on job searching. I actually found my first job because I called practices in an area that I was going to, like literally cold called, faxed my CV to see if it would work because I was very like geographically restricted. And that's how I got my first job. So you can always do that as well if all options run out.
I'm going to ask a question to Dr. Reinhorn and Dr. George. How do you have time, or how did you set apart time in your life to understand all of the ways that you get paid? And also, why is that important, you know, even for us in academic practice going forward?
You know, I took my first job having no background of what I was entering, and I went into a practice with a loan guarantee from a hospital. I thought I was going to work for a hospital, and they told me I needed to set up my own private practice, talk to an accountant and lawyer, and set up a company. And so I had absolutely no clue what I was getting into, but it turned out I liked it, and I thought it was really important to have some sort of fiscal responsibility on what I recommend to my patients, whether it's really in the benefit of society. And so I grew to like it, and then it became a necessity. You can't run a small business without knowing what's coming in and what's going out.
And that's a really good question to follow up on that. I was actually in private practice for a couple of years before I joined academics. And so it was very much suited towards trying to get yourself compensated for procedures. So, you know, a third of my time was marketing, a third of my time was clinical, and a third of my time was billing and doing all that stuff. So it really sort of made me learn how to do it because, you know, no one really teaches you. You know, there's no real courses on that. You know, when they don't teach you it in residency. They don't teach you it in fellowship, really. You really have to learn sort of hitting the ground running. So I think private practice really exposed me to that. And then it was sort of like automatic. I'm thinking about it all the time. My wife is a plastic surgeon, so she dreams in CPT codes. So she really helped me with that as well. And I think all that together, I taught myself how to do stuff. Sitting down with a CPT book for an hour, you'll like learn stuff you never even realized.
Another question regarding contracts. It's very intimidating whenever we sit in these conferences and we learn all about the things that we don't really know. Does anyone on the panel have mentorship or like intentional ways that they have worked with mentees and or trainees at their institution to educate them about this before it's officially time to look for their first job?
I can comment on that. I start badgering the fellows very soon about looking for their first job. Dr. Nowitzki, my senior partner, always says, no, you don't need to worry about that till many months later. But if you think about it, like in March, you should potentially have a signed contract. So if you start the process now, but I sit down with, they can attest to it. They're here actually in the room, that I badger them about that, ways to look for jobs, ways to look for opportunities. And the most important thing is coming to meetings like this and, finding people you're interested in areas that you're interested in. But I start the process very early, with all that.
So I don't really have anything specific. The first fellow that I trained is actually sitting right back there in the corner. And when he came up to me with his contract, he was getting paid more than I was. And I was like, I failed myself. I don't know what to do anymore, but you should take that job, was my advice.
I would just say, I think most of the trainees are a little nervous or not forthcoming with some of the information. So you really have to kind of pull it out of them. So last year, one of our fellows thought that a letter of intent meant that they had a contract. And so just really clarifying those sort of things with them. And I have found that actually talking about it with them in the operating room, if you're just getting access at a time when you can talk less about the case and more about those things, is a good environment where they feel relaxed and they feel like they can open up to you. And otherwise, I think they feel like they're going into it blindly, even though we tell them that we're a resource. So I would say if you're a current fellow, you should start the conversation with your faculty and your staff, because they're more than willing to talk to you about it. We just don't always know what part of the process you're at. So there's different stages. So let us know.
Yeah, I do think it's one area that we need to have some advocacy and discussions more about, make it more open to discuss. We don't like talking about money for some reason, but we should, because it's just money. You can be happy with a lot of money, you can be happy with a little money, but understanding that, right? Again, it's meeting. If you're feeling like you're getting shorted, you're not gonna be happy no matter what they're paying you, and vice versa. So ask your mentors, ask people, go on those websites that I put on there. There's a lot of great information just to get you thinking about and learning. I mean, a number of times I have to go back and remember what's claims made or occurrence based policies. It's a huge difference, and I forget about it every damn time.
Dr. Juso, question about the FTC and their influence on how we're thinking about this. In our community, it seems like there's been an upsurge of those physicians who either been moved out of one system into the other, and that there are more wanting to just ignore the non-compete clause from their contract, which means we've considered we're trying to weigh, is that worth fighting, and is the system going to go after them if they do break that? It seems that's getting very lax. Do you have an opinion on what's happening across the country?
I don't have an opinion. I have an impression, which is that I've heard of people who, I've got a non-compete, I'm moving to a hospital within that non-compete range. I'll see if they come after me, and it just puts all the power in their court. They can if they choose to. They've got the law of the contract behind them. I have heard of people who, it just becomes sometimes too expensive for either side to fight, and they just let it go, right? But you're basing it on a hunch, right? So, I mean, ideally, we should get away from non-competes. The intent, again, is for them to say, you learn something from us. We don't want you taking it somewhere else and then reaping the benefits of it. But in reality, it's just, I'm a physician. I learned a skill. I should be able to port that from one place to another without having to uproot my family. So I hope that this swings back and they are able to reinstate the FTC ban or they rework it, and non-competes become a thing of the past.
I can comment on that really quick. So my wife actually just spent 6 months dealing with getting out of a non-compete. And there's always a monetary value assigned to a non-compete. Sometimes in your contract, there's like amount you can pay to get out of it. I know a lot of major metropolitan areas, when people sort of bounce back around, the newer hospital system can pay that. I'm hoping that goes away. For instance, didn't look at contracts that had non-compete at all. I'm hoping that sort of goes in that way. I think it's great for if you have trade secrets, but if you're just a practicing surgeon without trade secrets, I hope it goes away at some point.
Hi, I'm Josh Davies from Boston Medical Center. I have more comments than questions. A couple of years ago, our residents were really interested in learning more about contracts. And so we actually set up a real world curriculum for them as part of their academic development time. And we go over all of this stuff with them. And then we follow up with them if they go to fellowship or into practice about 6 months after they start their fellowship, just to check in and see if they have any questions. And the feedback has been really great. And so it's really easy to put together a small curriculum for them, and it goes a long way. As far as the question about caring about CPT coding and making sure you're getting the most, we've had a slow development of kind of developing our hernia center there, but kind of tracking what we're doing, how much it's making the hospital has really opened a lot of doors for us. And so for those of us that work in hospitals and it's hard to convince them that abdominal wall surgery is important, that was a really key step in our development. So.
Yeah, I think regardless of where you are and where you practice, understanding the economics of what you do for the hospital is very important, because maybe you don't like the contract that you had when you signed, but you want to stay at that institution. Ways to negotiate things is to show that you are making money. And so I think irrespective of if you're private practice or academic, knowing how the hospital makes money and knowing how you make money for the hospital are really important, because it can help you negotiate more, research time, more things that you need across the board. So that's information that you should kind of, learn, but then your worth, or at least part of it.
Yeah, and I think that curriculum sounds great. And if you'd be willing to share, that'd be awesome. I would ask maybe, something you could do for follow-up is just see what the attrition rate is for those who have gone through that course, right? If the general public is 50% at 5 years, if you guys are 30%, that's a win. So, knowledge is power in that setting. So it's good.
Hi there, Vamsi Ali from Penn State. Just an anecdote and a comment for the rest of the people in the group. To build on Dr. Horn's comment about renegotiation, sometimes it's sort of a voluntary where you approach your employer. And anecdotally, one of my good friends is a plastic surgeon in private practice. They got bought out by a private equity firm and presented with a new contract with an exit timeline. So signed, and within 30 days, you can walk away with nothing. So his old non-compete disappeared the moment he signed his new contract, and then he walked away without, any sort of geographical limitations. So that might be some sort of miracle moment, but not for everyone. The comment was that the FTC ruling did not include nonprofit organizations. So for many hospital systems, if you're a hospital system or even a academic practice that's structured as a standalone nonprofit or under a university, that never covered physicians in those models anyway. And that was one of those weak spots. And several states have been lobbying from the grassroots physician level to change legislation. And there's been stuff that's sort of been for us, Pennsylvania, that's been caught in the State House for several years, but that's a sort of a state-by-state initiative. And there's certainly our national organizations are also still lobbying for that.
Yeah, it's a good point. I mean, there were a lot of people speculating or hoping that it would continue over, or at least that was the first chunk out of chopping down that tree. But, it all got washed in August anyway. So hopefully it comes back.
Well, I'd like to thank all of you guys for your excellent, we got one more question quick, and then we will wrap up. We'll end with your question, but I wanted to thank everybody in this panel. It was a great session, and thank you for all of your contribution.
I'm sorry to come back and drop one more thing. I want to go against Dr. Juza and say I actually had a good experience with a contract lawyer for two reasons. One, she was able to point out some vagueness that I could nail down in my exhibit page of like what actual expectations were. And two, I had a large portion of my contract, which was pretty much non-negotiable boilerplate. but she was able to tell me what that meant in lawyer language. So when it came to something like a non-compete, she informed me that I actually have one of the things in my contract is I cannot quote advertise if I move within a reasonable area. That's vague, but advertisement could be considered something as small as if I switch to a different institution and they announce that I've joined them. So that sort of helpfulness, kind of knowing what I might be up against if I move within the area, I thought was really helpful.
No, and that's great. I mean, you'll find good physicians and bad physicians. You'll find good lawyers and bad lawyers. Who'd you go through? Do you know? Do you recall the? Well, if somebody needs a good contract lawyer, go to hers, don't go to mine. There you go.